So, margines and colorectal de metastasis hepaticas. Sorry, I cannot speak. I can understand your language because of Spanish, but I cannot really speak fluently. So I will try to give my talk in English. And I may say at first that I am not definitely against what Oscar was sustaining. I'm just introducing a different perspective of the margin. So for me, the margin are important. The margin has been challenged by the surgeon that in the time moved towards the edge of the tumor to maximize our possibility to treat the patient, our possibility to face with more disease of the liver. So to provide solution in condition in which you have scattered a lesion bilaterally, because we know that for this patient, if we provide surgery, there is for sure an advantage in terms of long-term survival. And for better understanding what next in my lecture, let's follow the Maino analogy. Pietro Maino, Gilbenta Group, released this nice paper that was inspiring me, this analogy, which was introduced by himself. So this is a tree in front of his house, and he noticed that it was very similar with the liver. And the liver is a little bit more complex because it's in reality are two trees together, fused with the vascular skeleton of the inflow and the outflow. But anyhow, there is a resemblance. And then once you have to face with complexity, this resemblance may inspire you solution. Complexity means lesion like this one. Oscar has already seen this presentation a few weeks ago in another webinar. And well, if you tilt the liver in the way that it may mimic the tree, you should proceed with this analogy. And these are 35 lesions in the liver, and these are 35 apples in the tree that you have to remove. Well, major hepatectomy doesn't work in this situation. And even if you would like to try, anyhow, in this particular case, you would have resulted in a few liver remnant, anyhow R1, and in 2 of the 35 lesions, you should have done a ablation. This means that probably even the stage procedure would have been unsuitable. Of course, someone can say that if there is responsive to the chemo and given the good results of the transplant, probably this kind, and the disease is liver only, probably orthotopic liver transplant could be in the future a solution. Anyhow, at the actual time, we may say that, however, possibly there is a solution. And the solution is find the mainstream. We used to identify the vessels since just be under the first part of the dissection, just a few millimeters. Identifying the major vessel is possible. This is the hepatic vein. And then you can tunneling and directing, even without the ultrasound in some circumstances, the dissection as you would like to follow to include all the lesions that you want. And at that time, the ultrasound become fundamental because it drives you this kind of attitude. Well, with this policy, and if you consider, as Oscar has already said, that in reality in literature, the tumor margin exposure has been considered a disaster in this paper, a little bit more unfair than the other policy of larger tumor-free margin in this paper released by the Memorial Sloan Kettering, and by necessity is famous, this paper in 12 years ago, released by Paul Bruce, in which they were showing a similitude in survival among R0 and R1. We ran an interview which was published among 276 HPV surgeons from 52 countries, and by necessity, R1 is accepted in 53%. Well, but I'm not discussing in reality of R1 by necessity. I think that we have to get more deeper into the analysis of this parameter, because everyone agrees this is R0, this is R0, but this is R1 for sure, is the exposure of the tumor on the cut surface in between the parenchyma. But how to address this R1? Is it really R1 like this one, or is it something different? And the hypothesis that we were introducing is that in reality, when the tumor is in contact with the major vessel, is in contact with the burden between two different parts of the liver, fully anatomically separated by the vessel itself, then probably it is different than spreading in the adjacent parenchyma rather than in front of the vessel. Although, anyhow, there is the tumor exposure, but R1 parenchymal, R1 vascular probably are two different categories. Then we proceeded in detaching all the tumor with the major vessels. And in support of our hypothesis, recently has been published this paper on Journal of Hepatobiliary and Pancreatic Science in 2017 by Sujoka. He was proposing this paper just to sustain the Takasaki technique afforded by the laparoscopic approach. But in reality, it was introducing a concept which is supporting exactly the R1 vascular. So the major vessels into the liver are covered not only by, separated by the parenchyma, not only by the vessel wall, but also by the capsule, the neck capsule, which separate the liver from the inferior vena cava and from the exteriority of the organ, other than the glissonium. So there is a further structure that is a barrier between the major vessel and the tissue in the liver. Then is supporting conceptually the data that we have released in anastosurgical oncology, in which R0 and R1 vascular behaves similarly in terms of local recurrence. Then I am not sustaining that the tumor exposure is good, because the tumor exposure R1 parenchymal in contact with the tissue of the liver undoubtedly is worse than the R0. It is, as in every paper, the risk of recurrence is very high. It's 20% per patient and 14% per resection area, compared with 1.5 and 6.3% of R0 and 4.3 and 3.9% of the R1 vascular. But R1 vascular confirmed to be something different. In terms of long-term prognosis, this was confirmed, despite when we are introducing the R1 vascular, we are introducing more complexity. The patient who received R1 vascular were more complex than the other. And if you focus your attention to the hepatocaval confluence, the results are similar. You can detach just for the hepatic vein, you can detach the hepatic vein in most of the time. Once it is not suitable, you can remove just a part of the vessel, and patching is reduced to just the vast minority. Once you detach, the risk of local recurrence in a R1 vascular fashion is just 6% in this series published on surgery. Then at the end, we can say R0, R1 parenchymal is something different, but this R1 is probably a new category, R1 vascular. And this means a lot, because if you accept that this is a new category and the results are really what you are expecting, and you go back to the case that I show you, you can provide surgery in this way. You can detach the vessel. Then there are an infinite time kind of solution. This is the virtual cast of our operation. And this was the real operation. The cut surface drawn on the surface, and this is at the end the removal of all diseases, the detachment. This is a tunnel in between the left hepatic vein and the segment 2. We removed a lesion here in the axilla, another lesion here in the axilla, in contact with the Gleasonian pedicle of 8 ventral 1 and 2. And this was done to keep all this part of the liver, which was drained by the middle hepatic vein. And this is the schema of the operation. So a sort of vessel-guided surgery. Vessel-guided hepatectomy is the new acronym that we are trying to spread out. And this kind of technique may not work sometimes because you cannot detach, but if the detachment doesn't work, the liver is saying you something, and you have to listen the liver. Why? Because if you notice that despite the detachment was not feasible, we reduced the number of major hepatectomy to the vast minority. And this is because when you cannot detach, it means that the vein is strictured by the tumor so much that at the end, hemodynamically, the liver adapted already to the absence of that drainage with the collateral circulation. The collateral circulation can be identified and profitably identified and used to provide a solution that anyhow permit you to address surgery in a parenchyma sparing fashion rather than in a major hepatectomy. So the criteria are the R1 vascular, and when the R1 vascular is not feasible, the communicating vein. And the other implication is that when we have a multiple bilobar, as I show, we use to do a one-stage procedure with, even if there is a bilateral contact with the major vessels, 33%, and in this way, when you preserve the skeleton, you have the more chance to obtain also the possibility to reoperate in case of liver recurrence, this patient, because you keep the skeleton, the architecture of the organ, the bilateral R1 vascular. This is a case of bilateral R1 vascular. You have the detachment of the vessels in both sides of the liver. And recurrence, you can reoperate the patient because you keep the skeleton, you keep the organ, the structure, you have the same solution, other than the adhesion and the fact that it's a territory that you have already operated. But this, all of you have the experience to face with this condition. But on the other hand, in this case, this is the second operation, another tunnel. We want to preserve everything in the liver that can work. Reproducibility, well, this is the histogram of the activity of my team, 31 years old, the mean age, 36, 39. They are doing the vast majority. Now I am in vacation and they are doing the operation anyhow. And this kind of surgery has been anyhow spread around the world by many of our friends. Then we are challenging the two-stage and the halves. It means that you can reoperate, you can reduce to only one operation the surgery with results that are even better because you don't have the dropout. And furthermore, this is a comparison with the Paul Bruce, a case match with them, and the inclusion criteria were dictated by the Paul Bruce, not by us. And this one is another comparison with them, showing that the local recurrence is similar among the two series. It means that two-stage is not really selecting the patient, but we operate also those that would have been excluded by the two-stage because they dropped it out, and despite that we have despite this worsening theoretically of our series, the recurrence was exactly the same. And we were challenged by the Italian registry of Alps to achieve our complexity of 1 center versus 12 centers. We have to match only 1 to 2, one of the Alps group, 2 of our groups. So we had much more complexity than the Alps procedure. Despite that, the results, mortality was significant, was 1.7% versus 7% compared with the 2 series. Then also in this sense, there is an advantage. We have now proposed a new categorization of hepatectomy in which for the first time the liver tunnel and some other complex core hepatectomy that we have proposed in the recent years have been introduced. And this is what we are exploring. We are exploring something different. We are trying to keep just the core of the liver, the touching every part with the major vessel to enhance our capability to remove all the disease in a single operation, and probably exploring new limits of the future liver remnant, like in this condition in which we did this dissection. Definitely concluding R1 vascular for me is yes. R1 parenchymal, I fully agree, should be avoided. Thank you very much.